And thank you everyone for having me here today. So thank you for the lovely introduction, first of all. And I'm looking forward to share a part of my PhD research, which is the development of the making it meaningful instrument co-designed with the end users at one cancer service in New South Wales. This is me, and I acknowledge the co-authors and other contributors who contributed to this particular research project as part of my PhD, my supervisors, the consumer representative, co-facilitator, and the health service staff who are listed here as co-authors. Okay. We did the country of acknowledgement of the country, so I will skip to the next slide. So what is the session outlined for today? So I will start with some background, what formed the background for this co-design work, what was our aim in conducting this co-design and how we go about it, and what came out at the end. And in the discussion section, I want to open the floor to people here in this forum, implementation size interest group, because I want to know more about how this could be better implemented, how the end product or the MIM instrument could be better implemented, using what theoretical frameworks, and how we can actually measure the implementation process when we do so. And so applying the implementation science lens. So first of all, how safe is healthcare for ethnic minority patients internationally and in cancer services in Australia? Sorry, I'm not sure what I did there.
That's good.
Can you still see it? Yeah. All right.
No, it's not in presenter mode at the moment. Okay. We can see it first.
It says your screen sharing is paused. I'm not sure.
Oh.
You are screen sharing. Okay.
Yeah. All good.
All good. Yes.
Okay.
Sorry about that.
All good.
All right. So what formed the context or background for this research work? At the start of my PhD, I did some work with my primary supervisor, Emma Harrison, and we did work around consumer engagement, specifically for people who were from CALD backgrounds, and realized through our previous research that consumer engagement is lacking or is different for people who are from CALD backgrounds, and also that has impact on their patient safety. But there was not necessarily any evidence, synthesis around what are the type of safety events that people from CALD backgrounds experience when they are accessing healthcare, and what are the factors that could impact or increases vulnerability for CALD patients or for people who are from CALD backgrounds experiencing healthcare. So we did a systematic review, and this was a systematic review of 45 studies that identified that people who are from CALD backgrounds accessing healthcare, they experience higher number of medication-related harm, dosing errors, administrative errors, not able to understand instructions, how to take medication was one of the key factors among others. There were other socioeconomic factors identified as well. For example, people who did not have health insurance were more prone to safety events, especially in the countries like US, not in the European countries where there was Medicare. I guess the health services were freely available. But through this systematic review, it became apparent that consumer engagement, especially the patient and family engagement in their healthcare, is very important to enhance safety of healthcare for people who are from CALD backgrounds. Leading from this work, we did not identify any particular studies that looked at what is the nature or what type of safety events occur for people from CALD backgrounds in cancer services. There were no evidence around that, so we did a retrospective medical record review at 2 cancer services here in New South Wales to identify what are the common type of safety events occur among people from CALD backgrounds. And we also wanted to see if there is any link between being not able to having English as a second language or having non-English language as a language of preferred language, or non-English language as language spoken at home, and country of birth has any indication or has any implications or relationship with the number of safety events. So we reviewed 300 medical records of cancer patients from 2 cancer services, and they were all patients from CALD backgrounds. And we used four indicators to identify these medical records. One was country of birth, which was outside of Australia, language spoken at home, which was non-English, preferred language, which was non-English, and interpreter required, which was yes. So if any of those 4 indicators were present, then we would identify them as a CALD patient and review their medical records. So within that medical records, one of the interesting the type of safety events, it was the medication-related safety events was the most commonly documented or most routinely documented or most prevalent documented medical safety events in the medical notes. I guess there were other safety events as well, but there was some distinction in between the inpatient and the outpatient. So in the inpatient, the most safety events occurred around administrative errors, but in the outpatient, specifically for the medication errors, the type of medication errors or safety events were around taking wrong dose or not understanding how to take the medication or not able to follow the instructions around the care process as healthcare staff intended to. So we also did some content analysis of the notes that were present that was extracted from the medical records. And within those content analysis, 2 themes were identified, and one was around misunderstanding or miscommunication between healthcare staff and consumers. And also the second theme was around miscommunication between or improper communication between healthcare staff at different facilities, because cancer is spread around, not just in the cancer services, but there are many stakeholders or many health professionals who contribute to cancer care for patients. So communication, especially between the healthcare staff and consumers, that is patient and their care support person, became kind of like a most identified issue and key interest for this particular topic. So why consumer engagement for patient safety? So there is a lot of evidence around that patients are the constant element in the care that is spread around various health services, and they know more about what is happening to them than any other health professional or healthcare staff at a particular point in time. So involving them meaningfully in their care has implications for patient safety. There are many engagement strategies that are employed, and those engagement strategies like asking patient to or encouraging patients to ask more questions or raise concerns, but these strategies are not tested for patients or people who are from CALD backgrounds, because for example, I was part of a systematic review that was done as part of the project that my PhD was part of, and that project evaluated looked at the system, published literature that evaluated consumer engagement strategies that worked for patient safety, and we identified that there were 27 strategies employed at various levels, of which most were at the clinical interaction or face-to-face interaction. And of all these strategies employed, there was no clear indication if any of those strategies were designed by or designed with CALD population or tested with CALD population, because the data about that was not readily available. We also, based on this systematic findings of this systematic review, we did some focus group with the national stakeholders to identify what strategies could be employed or could be developed with to improve or enhance safety for people who are from CALD backgrounds. And through these focus groups, we identified that current engagement strategies are not completely suitable, but they can be adapted, or there is a possibility to do some adjustment to this existing strategies to make them feasible for CALD population for implementation. And so from this work, we did design the first co-design, which was co-designing with people from CALD backgrounds at one cancer service to see what is the issue that they would like to address in that particular cancer service. and how we go about developing this tool. So the aim of this co-design was to this presentation is to describe the process of adapted experience-based co-design, describe the process of development of making a meaningful instrument that came out as an outcome of this co-design. And then later on, we'll discuss through the implemented science lens, what will work if we need to, when we are implementing this at a large scale. So this project was conducted across 2 phases. So the phase 1 was conducted to identify what are the experiential and contextual issues or contextual features that are the focus. So in phase 1, we did the systematic review that I talked about earlier, the medical record review that I talked about earlier. And we also did interviews with health service staff and consumers. And for all of those findings, I'll present to you in a slide later on, which formed the basis of the first workshop. Following the phase 1, we also did a feedback event with health service staff at the cancer service. And this feedback event was around bringing the findings from the phase 1 to determine the scope, what could be the scope of the co-design. And then in phase 2, we conducted 3 co-design workshops with 2 CALD consumers or 2 consumers and 3 health service staff. We also engaged 1 consumer co-facilitator who was from CALD background and a multilingual field worker to support the consumers throughout the co-design to engage them more meaningfully and contribute them equally in the co-design process. So this was the co-design process. So we planned out a process beforehand. So there was a series of meetings, series of emails, and series of phone calls with the consumers and with the health service staff at various stages. And so this just gives a streamline of process. And these 3 workshops were conducted over a period of 3 weeks, so 1 week apart from each other. I just want to highlight 2 things that were, 3 things that we considered prior to starting the workshop. The first one was the preparatory phase. And in the preparatory phase, we wanted to make sure that we provide language, technological, and financial support to the members of the co-design team. So, for example, consumers to be able to create conditions for them to be meaningfully involved and equally involved in the co-design process. For example, for the language, because both the consumers were from Mandarin speaking background, we employed a multilingual field worker who spoke Mandarin and who had experience in the research. So they were not the interpreter, but they were one of the health service staff, and they have worked as a multilingual field worker with one of the local health districts since last 10-50 years. They have understanding of the processes, how the processes work in the health service, and that kind of helped a lot, I think, in terms of engaging or explaining the process to the CALD consumers. The second was the logistic considerations. So one of the thing that came out of the logistic consideration was providing participants with necessary information before the workshop. For example, what was the aim of the workshop, how the workshop would run, and what are the research or aims of each workshop prior to the workshops. We also made sure that any transport arrangement or for example, we booked the taxis for the consumers to come to the institute where we had the workshop, as well as then book the taxi for them to go back home. And that helped, I guess, in terms of for them to physically attend the workshops. We also checked, because we conducted workshop hybrid using a hybrid model, so online as well as face-to-face. And so we also checked prior to the workshop how the hybrid model would work. So, for example, one of the consumer, they attended the first workshop online and they could not use Zoom. They could only use WeChat. And we could not use WeChat on a big screen to share the slides, etc. So we used Zoom and the WeChat in the one room at the same time, with multilingual field worker present at the facility and having the conversation on the WeChat, and then the Zoom in the background doing the slide work. So preparatory phase in terms of testing those things, technical things as well, how they work, and so had the plan in place. but obviously certain things are not planned for. So you just have to mitigate, I guess, as they happen. The second thing in the preparatory phase, which was important, was involvement of consumer co-facilitator. And there has been some research around how they can enhance participation of consumers who are from CALD backgrounds more meaningfully and have them more engaged in the co-design process. So as part of this co-design, we train them in how to use online platform for co-design, and we also trained the consumer co-facilitators in what was the overall project, what we want to get out of this project, etc. So those were the two considerations prior to what we did the co-design. But we also considered that for the intended outcome or intervention that was developed to be implemented or tested, at least at the participating cancer service, it is important to involve or engage with health leadership, senior health leadership. So my supervisor, Associate Rima Harrison, she was in contact with the directors at the cancer service to make sure that we have that buy-in from them, that what came out of this co-design would actually be at least tested, or they would be interested in testing it and implementing it later on to achieve the positive outcomes or to realize the outcomes that we intend to produce. So prior to these three workshops, we also did an introductory meeting. And this meeting wasn't about the co-design process, but it for co-design itself, but it was part of a workshop because we were able to introduce staff, all the members to each other, test the equipments, etc., and plan out how the workshop would run. So we had this plan, how the workshop would run. Most of the participants attended the workshop in face-to-face, which was great because that just had really organic feeling to how workshops were run, and really organic feeling, I guess, that contributed to positive engagement and meaningful contribution of the participants or members of the co-design. The other important thing that was considered and implemented in this co-design process was integrating theory at each step in between the workshops. And this was important for us to consider because we want to develop an intervention that was based on theory so that we could also test it when we needed to. So that was an important step that was considered beforehand as well and integrated in the co-design process. We also made sure that we made contact with the members in between the workshops to make sure that if they had anything that they wanted to contribute or thought of after the workshop, they could bring those points before the next workshop. And we engaged with multilingual field worker for one of the consumers who was Mandarin speaking, so they can have a conversation with them in the language. Yeah. So this was the whole process, how the workshop happened over the course of 3 weeks, which took lots of work. So I talked about this earlier. So preparation prior to co-design workshop, in between workshop, making contact between integrating theory and co-design, meeting between co-facilitators. So we also, the consumer co-facilitators and the research co-facilitators met in between each workshop, and we planned out based on the consumer co-facilitator interest and what they wanted to contribute to have a run sheet as well to make sure the workshop ran smoothly, and what they wanted to contribute and how they wanted to contribute was considered in the workshops. And if you wanted to know more about the protocol paper is also published, and optimizing co-design, which talks about creating conditions for optimizing co-design with ethnic minority consumers. So the first workshop, so I talked about the phase one. The phase one constituted of the systematic review, medical record review, a document analysis of engagement frameworks used by the state and federal level health services and agencies that describes how consumer engagement should occur with people who are from CALD backgrounds. So those 3 studies plus the interview study that was part of the co-design with 15 healthcare staff and 4 consumers. And this, all the findings from this study were brought around in this one slide to identify what were the issue, that had been identified by the health service staff and by the consumers, and through our work through the systematic reviews, to range of problems that could be addressed at that particular site. So as you can see, I acknowledge that the arrow would make more sense if it's a round cyclical, because it's a cycle from entry to home care and then back to revisit. It would make more sense as a circle, but for the pictorial representation, I have used an arrow mark because it's for the ease of understanding. So there were several issues that came out from the interviews and from our work prior to the interviews, and these are the range of issues. And so the first workshop, our aim was to, from this range of issues, identify one issue that health service staff and consumer could agree on to address at that particular health service, cancer service. And we wanted that issue to be something which is feasible to address. So, for example, there were lots of issues. One was around interpreters as well. And we acknowledge that while interpreter is a major issue, it could be a system level issue, and which as a co-design, we may not be able to implement a solution that could be addressed in a time frame that we wanted to address. So so there were two main things. So one was identify the issue that we want to address, and also to see what is feasible for us to implement, like design a solution for and implement and test in a very short time frame at that particular health service. So after a 2-hour session and then emails over the period of the next few days, the staff the participants or the members of the co-design team selected this particular issue, contacting health service professionals in between appointments, as an issue to be addressed or develop a solution for. Now, both the health consumers who were part of the co-design team, they had experienced safety event where they were not able to contact the right person at the right time. And they had to either go to the emergency or show up late in terms of the next appointment when the condition got more severe. So that became an issue, and healthcare staff also verbalized that the current process that they had at the particular health service did not include. So they had cancer care providers or cancer coordinators that that coordinate the cancer care, but that service was not available to people who spoke language other than English, unfortunately. So there was no mechanism for at that particular service at the time for the consumers to know who to contact and when to contact. So second and third workshop. Second workshop was around, so we identified the issue, which was the making the contact in between the appointments for urgent, non-urgent issues. And so the second workshop was around understanding the process. What was the current process, and how it could be adapted to suit the needs of the consumers. So you can see the picture or image on the right-hand side of the screen. And at the end of the appointment, I think, or chemotherapy appointment or a treatment, they were provided with this template or information for important things to remember. For example, if you're a chemotherapy, do this, and then contact us in between these hours on this number. But as I said, that the current care process did not accommodate the language support needs of the participants. This was not available in other languages. So participants relied heavily on their oncologist. Whenever they had any issues, they rang them, and they felt that they were overburdening them, so they did not ring them on the time. Or sometimes when the oncologist was not available, they did not have anyone else to contact. So that was an issue. So in the second workshop, we wanted to identify, okay, what this information should look like for the participants to act on, to be able to make them make the contact in between the appointments easier and at the right time. So there were three things that were identified in the literature: that the information should be accessible, should facilitate effective communication and interaction. And we discussed around the current care process and how that could be incorporated. And there was this shared agreement at the end of the second workshop that to develop a tool that would facilitate effective understanding and communication about medication side effects and who to contact. So we narrowed down further to, okay, so they are given information, but their main concern is around the side effects of the medication. And they do not know who to contact if they want more information about what are the side effects to look out for apart from their oncologist. Did not have so we decided that the intervention could be that to develop a tool. And so in third workshop, we planned the process. So we examined the current process of information sharing and then planned the process. Okay, this would be the process and this would be the tool that came out at the end of it. So what came out at the end was this 2-page tool, which was around the side effects just listed, most common side effects of treatment listed on one side, and this to be translated into Mandarin, simplified Chinese or Russian, because those are the two languages that we are focusing on for our feasibility study. Participants during this workshop, especially in the last session, also identified that to have a blank section for the notes, and this was also backed by the evidence that this could be used by participants to or consumers to make their own notes about certain things, and also could be used by the oncologists or medical practitioners as a space to demonstrate what are the things, or draw pictures, or provide some other form of communication. There were two things from that form, the previous form that I showed you, that was highlighted about, okay, so there are two different mechanisms around who to contact. So if they experience these symptoms, then they need to contact emergency. They don't need to contact the care coordinator for these symptoms. But if they won't have any questions about treatment appointments or plans, then this is the specific person at their care service who can be contacted on this phone number. So this was translated into simplified Chinese and Russian, and we are doing a feasibility study to test if this can go ahead as a large-scale trial before we test it as a large-scale trial. I wanted to talk about two things before we go around a broader discussion around implementation science theories and processes. I guess from my view, because this was more focused on co-design, especially with people who are from CALD backgrounds, and what kind of created involvement and engaged discussion with them was the organic process of the process that the schedule that I outlined does not kind of convey all the work that goes into doing co-design and creating that environment for them to, I guess, be able to freely talk about their conditions, and especially also the environment where that happens, the discussion happens, also have impact on that. And as a tool itself, the Making a Meaningful Instrument, it aims to enhance the understanding of medication side effects, which was identified as the most common, the issue that the co-design members wanted to address. And essentially, it enhanced consumer engagement by empowering them to identify the symptom or the side effects and take action at the right time. So as I said, it's being translated into Mandarin and Russian, because those are the two main languages that the cancer service that we are trying to implement this tool or do a feasibility testing. And we are also involving, to a large extent, mostly the health service staff at this stage, and to some extent, the consumers as well, to be exchange agents for the successful implementation of feasibility testing of this tool. I forgot to tell, but we had also been engaging with the consumer advisory group of the Can Engage project. And this consumer advisory group is a membership of 5 different consumers who are from 5 different language and cultural backgrounds, and they had contributed to designing the feasibility study, feasibility testing, and the study as well for this tool. So I was able to find this table, that one of the resources that Sam sent to me when I was preparing for this session. So this was by Jeffrey, and it's harnessing implementation size to improve care quality and patient safety. And I was reflecting back on the success factors that were listed on the left-hand side of the table here, and trying to see what we did in our process that that kind of speaks to it. And I guess in preparing for change, I guess there is a, and some of it also relates to the change management theory and models that that I've done some work with, and I could see the similarities in terms of preparing for the change, in terms of preparing the participants, preparing the consumers, and just the need that there is a need to implement safety interventions for that enhance consumer engagement for patient safety for this particular population. But yeah, so desirable implementation features. So, I did had one capacity. So building the capacity, so there are enough people with necessary and synergistic skills to implement the initiative. And I think we did find through our consultation with the senior health leadership and the healthcare staff within the co-design group that they are very keen, and they had really strong desire to implement something that would improve the safety outcomes for people who are from CALD backgrounds. There is so I could see that based on this table, there are features that are part of our core design process that contributed to, I guess, that could contribute to successful implementation. But I wanted to ask, I'm going to, minimize this, but I'm going to ask the wider audience now, like these 2 questions: what are the best theoretical frameworks suited to support the successful, suited to support successful large-scale implementation of the MIM, and what are the best approach to evaluate the implementation process along with the safety outcomes as such? So open to questions, but we can come back to this 2 questions later on. But if you have any other questions around the co-design process or the project, I'm happy to answer and then go to these 2 questions.
That was fabulous, Ash. Thanks so much.
Sorry, I've been running very fast, I think.
No, that was so comprehensive. That was really interesting. Thanks for highlighting, you know, just how important it is to consider these factors when engaging with CALD consumers to ensure medication safety. So just to kick off, I wanted to ask you to clarify, so your design for the study, you said it was theory informed, and you integrated theory with consumers' preferences. And which theories did you use?
So we didn't use specifically any implementation science theory. So when I say implementing theory in co-design, so for example, big questions, what are you hoping? All right, I'll come back to that later. So integrating theory in co-design. So in the first workshop, we identified the issue, and the issue was to who to contact and who is the best person to contact in between the appointments, because that was the one issue that was democratically selected by the co-design team members. And so going back to integrating theories, like we went back to the literature to see what is the information, what kind of
the evidence base, right?
Yeah, so,
okay.
So the 3 things that were identified were the effective communication, something which is integrate meaningful conversation. So those 3 things were the 3 main things. And then we took those 3 things. So in our second workshop, we printed out the pages of those 3 things. So effective communication and the 2 other things on 3 separate walls of the room here. And then we discuss, okay, what does this look like to you?
Right. You use the evidence base. Yeah. Now you're interested in rolling out the feasibility trial, and you're looking at potentially using implementation science.
Yeah. So that's how the broader questions for the group. Yeah.
Fabulous. Okay,
Yes.
let's open it up. So we have one question from Joe. Questions. Where are you hoping to implement with and which healthcare professionals, GPs, pharmacy, hospital?
So this is in cancer services. So in outpatient as well as inpatient. So this is like one cancer service in New South Wales. So the MIM can be used at the end of the appointment with the discharge. So our plan is to that the patients who are giving discharge information about their medication, they will be provided with the MIM tool as an additional information. So the doctor will be explaining to them, or oncologist would be explaining to them, these are the, or at the end of the treatment or after an appointment. So these are the main side effects that could occur because of the treatment or the process or the treatment that you will be going through. If this occur, then these are the person who you should contact. And if this occur, then these are the, I know a pharmacist will be a key here too. Thank you. Yes, I was just thinking about that. And yeah, but I think what we have done in our protocol is we will be going through the oncologists, because they are the they had been the point of contact for the consumers so far, because they were the source of the information. But I understand the pharmacist point as well here. Yeah. So.
Does anyone have any questions, information, feedback to share with Ash?
Yeah, so practical tips and examples about how you maximize engagement in the workshop. So I guess practical tips. So I will tell you about what we did in terms of the activities that we used to engage conversation. So we use something called the participatory learning action technique. So there are workshop brainstorming and voting and commentary chat. So the first one was brainstorming, and what we decided to do was not to brainstorm as a large group, as one group, but break up the groups as a smaller group, so people can have a chat with each other first, and then present their overall synopsis or topic or finding or what they discussed to the group in a later stage. So this made sure that everybody had a chance to contribute, instead of just opening the discussion to the whole group where 1 or 2 person could take over the conversation. The other thing was voting or doing the preferences. So everybody was given a chance to vote on their choices, so that that allowed everybody to meaningfully engage as well, and raise their concerns equally. And the other thing was important, like this was very organic process, and in terms of where engagement occurred between the members as well as during the tea breaks and during the recreational breaks, where people would just mingle and not talk about and talk further about what they had thought, and then bring those ideas later on to the second part of the workshop as well. So the workshops were 2 hours with 15 minutes break in between. And so first workshop activities, break, second workshop, then the activities again. Yeah. So those were the practical tips of the workshops itself. But again, as I said, making sure the transport is arranged, making sure they are provided with the information beforehand, the multilingual field worker, and making contact in between the workshops. That all helped, I think, with the meaningful engagement. Yeah.
Great. Thank you. Steph.
Hi, Ash. Thanks a lot for that presentation. It sounds like you've managed to fit an awful lot into a very short presentation. And it kind of blows my mind the amount of time and effort that needs to go into these kinds of events before they happen. And then I'm hoping that it kind of like runs nice and smoothly. And that's all people see. And they kind of see a couple of workshops and they go, yeah, well, yeah, you know, running, but it's all of that effort beforehand. And it's a really interesting piece of work around that whole sort of the cost of implementation, isn't it? Because we need to be resourced to be able to put this correct amount of effort into doing this kind of work. One of the questions I wanted to ask you, Ash, was how did you find running the sessions as hybrid sessions? Because they can be quite challenging to do in any circumstances, but if you've got a group of people who don't necessarily have English as a first language and you've got translators, and so I was just really curious as to how that interaction went.
So for all 3 sessions, 3 workshops, so we did 3 workshops, and all 3 workshops, 1 person was online. The rest of the person were face-to-face. So as such, there was good in a way because most of the people were face-to-face. And for each workshop, there was only 1 person online. The first workshop where one of the consumer was online or was not able to attend physically was a bit difficult because we had to coordinate with the Zoom, with the WeChat. And having a multilingual field worker works, as in like they were able to gauge their engagement with the consumer. Otherwise, that could have been easily missed. And I think the consideration of time as well. So we plan the session considering the time because we will need double time if we are having consumers. But the other thing that we did in terms of the structure of the workshop, that because we had activities that were kind of grouped, we made sure that people were grouped online as well in terms of their participation. So they could talk or they could have a group participation. Yeah. So those kind of things worked. But again, I don't know how it would be if the split was half, like 50% of people were in face-to-face and 50% were online.
Yeah.
I'm not sure how could that have done. We did think about it and we did prepare that we might have to do chat rooms, individual chat rooms, if there is more than 1 person or 2 person present on the Zoom, so we could use the chat rooms. And in the previous workshop, one of the workshop that I presented findings to, we also had used functions such as voting, chat rooms, in those using the Zoom. So we had used some of those techniques tools before, but yeah, because this workshop only 1 person was online, I think it worked in some way. Yeah, but digital exclusion can happen, and it's an important thing to consider prior to the workshops. Yeah.
While we've got you here, Steph, would you be able to share one of your, Steph has such a vast amount of experience with implementation science. Have you worked with, I mean, you have, but would you like to share an experience of, I don't know, a particular framework that you've used? Is it during implementation or post? Are you mostly interested, Ash, in like post-implementation evaluation?
So, for example, if I'm doing a large scale, so the evaluation would be of the outcome, which is the patient safety outcomes, but also the evaluation of the process. So if that process worked or not, or how could that process be enhanced for future, I suppose. Yeah.
Yeah.
Or yeah.
Because you're not really at that large scale implementation.
No, not yet. Not yet.
Kind of like looking to the future, isn't it? Sort of thing.
Yeah, it's looking into the future. Yeah.
You're at that kind of like MVP sort of type stage, aren't you? Where you kind of want to test out and see if this is actually going to work in the first place. And I think probably one of the things that was going through my mind as I was sort of reading these questions and as you were presenting is we know what the problem is from the consumer perspective around this sort of communicating in between sessions and come up with a solution. But I'm almost not sure whether we really understand exactly what the context is in which you're going to be putting this. So it speaks to Joe's comments sort of earlier about sort of pharmacists they would be quite key in this. It's almost about being able to understand what the barriers and enablers are likely to be that we're going to be importing this solution into. So we've often we kind of talk about identifying what the problem is and generating the solution and then implementing and evaluating. But I almost wonder what I'm not quite sure about is whether this needs to be a behavioural assessment. Is this something that the oncologists are going to struggle to implement, or are there going to be some reasons behind why the oncologists might not be able to use this intervention? Or is there going to be something from the consumer perspective? But I think you've probably got that much more sort of understood from that sort of perspective. So I think it would be, for me, in this first step, it would be about identifying what those barriers and enablers are, and then being able to measure those. And I'm not sure in my mind whether it's clinician behaviour or if it's a resource issue or what it might be. So I might need to sort of understand and unpack that a little bit more.
Yeah.
I mean, there's a whole range of theories
Yeah.
and frameworks. You know what implementation science is like. So you look around and another one's turned up, isn't it? So I think it would be about sort of identifying which kind of direction you wanted to go down, and then that would help lean you towards what kind of framework that you'd like to use. And then that would then inform the kind of data collection that you might want to be doing.
Thank you. Yeah, that's a good point. Barriers and facilitators, because when we collected interview study or interview data, it was around experiences of the service, because this was experience-based co-design, so it was more focused on experience. But I think we might have some, and when I analyzed the data, it was from that perspective as well. What came out in the interview was, in the workshop, was the process itself was not contingent or compliant to the needs of the CALD consumers, in terms of they have a care coordinator who other people could contact, but not the CALD consumers themselves.
Yeah.
Yeah. But
so it sounds like you've got a great intervention, but it's just working out how that's going to fit into the complex
health system. Yes.
Health system that we know healthcare is kind of thing. How are we going to get that there?
So starting with the barriers and facilitators to see what are whether this behavior or some other thing, and then going from there to address the issues. Yeah.
Okay.
It says in the chat, following up from what you were saying, Steph, that looking at the barriers and enablers and developing strategies. So it looks like another co-design process with healthcare professionals. Because yes, it looks like you've got a great grasp of the consumer side of things. And Joe also said which framework that you choose will depend on your methods too.
Yeah. Thank you.
Kind of a chicken and egg. Egg, chicken and egg, isn't it? It's sort of like growing those.
Any comments? Any other comments to Ash? Anyone want to share their experience with implementation science or ask Ash any other questions?
Could I ask one more question if there isn't another one?
Yes.
Ash, can I ask you about the medicine review that you did sort of early on? You did the systematic review and then you did the medicine review, and then you identified 4 criteria that if anybody hit any of those, then you'd consider them somebody from a culturally linguistically diverse background. How did you find the data when you went into the medical notes? Did you find it was relatively easy to pick this kind of information out, or?
So it depends. So obviously it was a bit difficult at the start because it's a different system. So I did it across 2 services, and those 2 services use the same system for inpatient, but different EMR system for the outpatients. So they have information is laid around, and in what way it is captured is different in both the services, slightly different, or I guess different. It's different in services. So what I did that in terms of the identification, I was able to identify people who are from CALD background based on the country of birth and based on the indicator, the interpreter required or preferred language. Language spoken at home is not routinely collected. I have found that. It's not one of the 4 fields that is routinely collected in the EMR. So it's either preferred language, interpreter required, and country of birth. So those 3 were largely available to identify somebody who are from CALD background. In terms of identifying safety events, so we had a duration of 1 year. So we identified the starting point would be the first episode of care. The first episode of care is when the consumer came in contact with the health service for treatment, diagnosis, any kind of appointment with the health service, and then we followed from that first episode of care to 1 year period, starting from the first episode of care. And this was it gives us a consistent timeline to review for all the patients, for all the medical records. So we followed each medical record for a 1 year period from the first episode of care. And then I read the notes. So we used something called oncology trigger tool that was used by the colleagues to help us to, I guess, speed up the process to identify which records to review. If nobody had a trigger that was identified in the oncology trigger tool, we did not review them because they did not have any trigger to warrant a review. and the people who had triggers, then we reviewed the medical record for that 1 year period. And I went to the notes and read the notes, read the correspondence. So it varied from person to person, the time spent. For example, for one patient, I may have spent like 4 hours to review the whole review, but for somebody who only had like very minimal presentation, it would be just like 10 minutes or 15 minutes.
Yeah.
So yeah, we used the oncology trigger tool to first identify what records to review, and then read the notes, and we had a data extraction sheet developed, so extracted the data and read the notes accordingly.
Yeah. I think the challenge is often that sort of, so we talk about, reviewing people's notes but the trouble is so many of these fields aren't necessarily compulsory. And
And
you've been in that clinical situation before, and you kind of, you just want to get this patient registered and get them into a bed or whatever it might be, kind of thing.
Yeah.
So if a field isn't compulsory, then that's the sort of time where, you might leap over that, or it might be a bit difficult to have a conversation. So I was just intrigued to know whether, how much joy you'd had in finding some of these fields filled.
Yeah, what I found from this records that patients or the consumers who are born in Australia but could speak a language other than English are not identifiable through medical records, because this information is not captured. So that whole population is underrepresented or not represented effectively in the studies. Yeah.
Thank you, Ash. Thank you.
That's a bit concerning, isn't it? Sort of like an invisible. Yeah, not fair. Glad you're doing this work, Ash. Anyone else before we close the meeting? I've given you a lot to think about, Ash. So it looks like the next thing is really identifying the healthcare professionals that are going to be involved, and what needs to be done, what are the challenges around implementing a new tool. And you've got as well, you want to keep the consumers involved as change agents you want. So, that needs to sort of somehow be involved in the process. But hopefully this discussion has sort of given you some ideas for moving forward.
Oh, definitely, yes. Thank you, yes.
Amazing. All right, everyone. Well, thank you so much for joining today. This recording will be going up on the AIHI YouTube channel. Thank you, Ash, so much for joining us, and see you all next month. Bye.
Thanks, Ash, and thanks for sharing, Sam.
Thank you. Thanks, Ash.
Sam,
Thank you. So notes is running out of tea.
can I ask a question, Sam? Just for you.
Yeah, sure.
Can you include me in the group for the next sessions?
Yeah, sure thing.
Just like on the email list, please.
Are you not included or already?
I don't know.
Me too, Sam. Could you include me?
Yeah, of course.
Yeah.
I will include you, Nima. No problem at all.
All right, then. Thank you, Ash, for a wonderful presentation.
Oh, thank you for listening. Thank you.
No worries. Have a
Thank
wonderful
you for
day.
having me.
You see,
Bye.
Nima.
All right. Thank you, Sam.
Elise?
See you this week.
Elise, is
when you are
there
here.
anything you wanted to say?
No, thank you. See you this year. See you this week whenever you are here.
See you soon, Ash. Thanks so much.
Bye bye.
Take care. Bye.